into respiratory diseases, things of the lungs, and upwards also, nasal passages downward really. So anatomy, brief review. Upper respiratory tract, or your URT, is going to include your nose, pharynx, larynx, or your voice box, your middle ear, and your eustachian tubes, which are the tubes that connect your ears to your nasal passages. So a lot of times when you get a cold, often you'll get an ear infection after that. That's because they're all connected. Saliva and tears in these areas protect the mucosal surfaces, like in your nose and in your back pharynx, larynx, all of that area. Then you have your lower respiratory tract, or your LRT. That's everything below your pharynx, basically. So trachea, or your windpipe, and then that branches into bronchial tubes that go into your lungs, and at the end of those lungs you have alveoli. That's where the actual gas exchange happens. Remember when we talked about innate immunity, we have the ciliary escalator, and that's constantly moving whether you're breathing in particles or not. But things get trapped as you breathe them in. They'll get trapped in mucus, and then your cilia keep beating in one direction to move that mucus upward back out of your airways so that you either cough them out or you swallow them. Alveolar macrophages are going to be located in your alveoli. They're constantly patrolling there, and they're picking up things that make it all the way to the sites of gas exchange. And then you have respiratory mucus that's going to protect all the mucosal surfaces from your trachea all the way deep into your lungs. So upper respiratory tract, we get a cross-section of you here. So nasal passages, and you can of course have, when you have a nasal headache or a sinus headache, that's because these regions called the sinuses fill up with an infection, and then fluid and edema build up there, and you get the pressure on your skull. Nasal cavity here, so you can have an infection anywhere from here, and then this goes back to where your windpipe is. Here's the back of your throat here, so these are connected, and then assuming you don't try to talk and eat or drink at the same time, air then goes downward into your trachea, and this area is sealed off. That closes off your esophagus where food goes down. And then this will go downward. So here's your larynx or voice box that helps you talk. That's when you get laryngitis, that gets inflamed and you have a real hard time talking. Your epiglottis is this piece of cartilage that works as a flap, and it sits over this when you're swallowing food. So you'll actually chew up food, push it back in your mouth when you're swallowing, and that pushes this flap down to close off your trachea so that food doesn't go into your lungs. There's your pharynx, this basic area that's the back of your throat, and or relative position. Here's your esophagus, which is right here, and then here's your spine. Oh yeah, and here's your eustachian tubes. You can see they're connected here and here. So if you're laying down and say you have a throat infection, bacterial viruses can go outward and give you an ear infection, or vice versa. If you get an ear infection, things can go back and cause a throat infection. Lower respiratory tract, so everything, here's the trachea, top of it here, that's where we were here. So everything trachea downward is going to be part of your lower respiratory tract. So larynx, pharynx, trachea, that's where we're at here. Then this branches into your bronchi, or main stem bronchus, which goes one into each lung. Then those branch into bronchioles, which are smaller pipes. And then way at the very end of that is where you have these alveoli, these little grape-like structures, and that's where gas exchange actually occurs in your lungs. So each of these clusters is covered in a whole bunch of capillaries that are transporting blood. When you normally have blood going through your body, it becomes deoxygenated. Then deoxygenated blood gets pumped from your heart, makes it to your lungs, and as it's crossing over this, carbon dioxide is going to diffuse from your bloodstream into your alveoli, and that's what you breathe out when you exhale. And at the same time, oxygen that's higher in the air is going to diffuse inward into the alveoli and then go into your bloodstream. And you can see these are, if you did a cross section of those, these are open like this. So you can totally get an infection with bacteria or viruses or fungi or anything that you breathe in. If they're small enough, they can make it into these alveoli. And that's when you develop pneumonia. So now we're actually going into the types of infections that hit these areas. And again, we're just going to hit a few of them, just by lack of time, but there's lots of infections we're not covering. Now I'm not even going to try COVID, because COVID's been burned out on that for 2 years now. But basic terms, pharyngitis is just inflammation of the mucous membranes of the throat. You have an inflamed pharynx, you have a sore throat, same idea. Laryngitis is infection of your voice box, where it actually affects speech. And often these two go hand in hand. If you get pharyngitis, you also develop laryngitis. Tonsillitis is going to be inflammation of your tonsils if you still have those. Usually it's caused by the same microbe that causes pharyngitis. This whole area will get inflamed. They used to think that, strep throat especially was related to having your tonsils, and for a lot of people they started taking out your tonsils and to see if your strep throat went down. But then looking at thousands and thousands of patients, they found, there's no relationship with that. The overall number of cases that still happen of strep throat is still the same whether you have your tonsils or not. But a lot of people will still swear by that, like, they took my tonsils out and I haven't had strep throat since then. That might just be a coincidence that you got immune to it enough or it doesn't happen anymore. Sinusitis is going to be infection of a sinus specifically. You have heavy nasal discharge. Usually this is self-limiting because it's limited by the area of your skull also. So there's only so much nutrients and so much space for bacteria or viruses to replicate. Epiglottitis, this is inflammation of your epiglottis, that thick piece of cartilage that sits over your windpipe. This normally prevents food from entering the trachea. If it gets inflamed, either it'll seal shut and not flip back out, or it'll flip out and not sit back down because it's just inflamed like that. So this is the most life-threatening disease of your upper respiratory tract. And this is going to be caused normally by Haemophilus influenzae type B. Remember when we talked about it before as an infection, Haemophilus influenzae, it's one of the things that's now vaccinated against, thankfully. But it still can, if you aren't vaccinated against it, it can totally kill you. Especially if you're a kid, you tend to have these cases. Poster child for upper respiratory tract infections is Streptococcus pyogenes. The same strep pyogenes that causes a lot of the skin infections we talked about. So here you have local invasion of our throats. When you get streptococcal pharyngitis, this is what's commonly called strep throat. And this has a distinct set of symptoms different from like, my throat's feeling a little scratchy, I probably have strep throat. You can get a sore throat from pretty much any infection of the back of your throat. So more often than not, you do not have strep throat in that case. Strep throat, you'll be able to see how badly inflamed it is. Most people will have at least one infection in life, and some students still say, I have strep throat once every year. Some people just never develop good immunity to it. Others, I had it once as a kid and it never happened after that. You'll have multiplication at your mucous membranes that causes initial redness, edema, enlargement, and tenderness. Makes swallowing really difficult and painful. A lot of people, I don't have an appetite because it hurts to swallow, or they'll just suck on ice or soup or something that's easier to swallow. Tonsillitis is the same then, except it's an infection of the tonsils instead of these pharyngeal membranes. Other symptoms can include fever, headache, nausea, and abdominal pain as it spreads from there into the bloodstream especially. Signs will include swollen lymph nodes, especially those around your neck, at the base here, and then pus-filled abscesses on your tonsils that look pretty hideous when you get to show them off. So general pharyngitis with someone that's had their tonsils removed, just a general inflamed area, pretty swollen. And then someone that still has their tonsils, these are those pus-filled pockets that you see all over the tonsils. Then you can also have that progress to the next stage where it becomes a systemic infection after you have strep throat. And that's when you can develop scarlet fever or scarlatina. It's caused by just one strain of Strep pyogenes that actually is infected with a bacteriophage, and that bacteriophage is actually giving the bacteria the potential to cause scarlet fever. So it's a specific toxin called erythrogenic toxin, which of our processes of gene transfer is where you can get a gene from a phage into a bacteria. Jordan can pull this off. It's what's the name of the type of gene transfer where you spread a gene from a bacteriophage to a bacteria? I'll give you 3 choices and you tell me which one it is, either conjugation, transformation, or transduction.
Transduction.
Yes, transduction.
Yeah.
We have some memory in there. Not much, but a little bit. We recognize it when I say it. So, it's often a continuation of pharyngitis or tonsillitis if you end up getting it. So you'll get strep throat first and then it progresses to this. If you have that, then high fever, and then you get this characteristic bright red rash over most of the body. And this can happen whether you're an adult or a kid. Eventually your epidermis will slough off, usually within about 10 days. Basically like you went to the beach in the summer and got a really bad sunburn. On rare occasions, it can disseminate into your lymphatics and your bloodstream, and that can lead to septicemia also. So here's that pinkish red rash that forms all over the body. This isn't from like jello shots, this is actually strawberry because of the actual inflammation of the tongue that happens. So this is where it's progressed from where it was in the back of the throat, and it's migrating outward like this. So first place to get hit is going to be your tongue, and eventually then the rash will migrate all over the rest of the body. Next one, diphtheria, caused by the bacterium Corynebacterium diphtheriae. Gram-positive rod. This one is pleomorphic, so it can change its shape around some. This one dangerously causes a tough grayish membrane that forms at the back of the throat. And this membrane is made up of fibrin, protein that naturally forms clots, dead tissue, like dead cells from the back of your throat, and the bacteria themselves. And together, this membrane can block off passage of air to your lungs because it basically just seals off that passage over your windpipe. Has an exotoxin produced by lysogenized bacteria, again bacteria that have been infected by one of these types of phages. This exotoxin affects protein synthesis, so your cells can't produce proteins. Circulates in the blood, then damages the heart and the kidneys as it goes from there. So initial infection in the throat, gets into the bloodstream, goes everywhere else. Start off with sore throat, fever, general malaise, and neck swelling. Spread by droplet transmission. Someone you're infected, you can spread it to your other siblings or parents or other family members. This one's also prevented by a standard vaccine, the DTaP vaccine. So diphtheria, tetanus, and pertussis. This is the D of that vaccine. It's a toxoid vaccine. Specifically, the part that goes into the vaccine is a portion of this toxin, not even the bacterium itself. There's a few cases in unvaccinated children every year in the US, and unfortunately that one's coming back also. Used to have the cases way down, but now with just COVID and hating vaccines in general, now also things like this are coming more in numbers. So here's that kind of tough membrane that forms in the back of your throat. Here it's sealed off half of this person's throat. Here it's sealed off the entire back of their throat. So no air could go from what they breathe in. It won't go back there because that airway is sealed off completely. Then usually they just have to go in there with tweezers or forceps and actually pull out the membrane physically. So it's not like they add anything to dissolve it. They just come and rip it out of there.
Ew.
Then, viral diseases of our upper respiratory tract, something we're very familiar with, the common cold. So there's actually over 200 different viruses that cause the common cold. Rhinoviruses make up the majority, 30 to 50% of common colds. Coronaviruses, relatives of COVID, cause about 10 to 20% of common colds. RSV and parainfluenza virus cause about 10 to 20%. RSV is coming up in kids more and more in the winter time. And then less than 10% are another one called enterovirus B68. That one's becoming more of a nuisance in recent years. We all have had common cold many times in our lives, so sneezing, nasal secretion, congestion. This can lead to laryngitis and also ear infections, so otitis media. It's not accompanied by a fever. That's one of the ways to tell that it's a cold versus the flu versus COVID. You'll have sneezing and secretion, but you don't develop a fever. It's not 100%, but 95% of the time, if you don't get a fever, but you have that sneezing and congestion and all that, it's a cold. Antibiotics are of no use on this one, even though a lot of doctors will prescribe it, or you'll try to take old antibiotics you have in the medicine cabinet. But it's a virus, so antibiotics will have no effect on them whatsoever. Only option is relief with cough suppressants and antihistamines. Antihistamines because as an immune response, your body will have your mast cells degranulate. So again, the antihistamines can help against that by neutralizing the histamine that you've been releasing. Specifically, rhinoviruses are the ones we're going to care about for this. So there's over 110 different serotypes of human rhinovirus that cause the common cold. And your immunity to any one of them does not give you any immunity to any of the other 109. So even if we've had, say, 20 or 30 colds in our lives since childhood, that's only immunity to those 20 or 30, not to the other 70 or 80 that are out there. That's why there hasn't been a vaccine for the common cold yet, because you would have to put portions of 110 different viruses into one vaccine. This just isn't, feasible and doable. So it's not practical to actually make a vaccine. The virus is sensitive to acidic environments, though, so it's restricted to our upper respiratory tract. You can't swallow it and cause an intestinal issue, even though a lot of people say, oh yeah, I lost my appetite or I have trouble with digestion when I get a cold. That's because of your immune cells producing all their cytokines and other chemicals, but not by the actual virus itself affecting your digestive tract. It has an optimum replication temperature of 33 degrees Celsius, which is why it's restricted to that upper respiratory tract. It doesn't do well at the normal body temperature of 37, like the 98.6. It prefers something closer to like 93 or 94, which is what you have in your nasal passage. So that's the perfect environment, but that's also the restricted environment. On the epidemiology, infections are going to occur throughout the world, all times, so you can totally get a cold in the summertime also. All age groups are affected. If you've never been exposed to that strain of the cold before, you can totally get it first time as an adult in the summertime. A lot of strains and serotypes tend to be circulating in a given population at any one time. So like in Tulare County, there might be 3 or 4 different strains of the virus that are going around, and they'll keep going around until most of the population has gotten them over a year or so. And then whatever new strains come into the area will then circulate again until they get most of the people. Herd immunity is only protective against one strain, so it doesn't help against any others. And this one tends to mutate pretty quickly also. So even your immunity you do have against one strain may not protect you against that same strain a couple of years later if there's been enough mutations. Spread easily by things like contaminated hands, those non-living surfaces like faucet handles and doorknobs, the fomites, and sometimes droplet nuclei from when you cough or sneeze. Children are especially susceptible. They come home with it and they spread it to their families, and I'm sure all of you that have families are angry about that in a loving sort of way, but very common for that to happen. infection of your nasal mucosa or your epithelium, and sometimes it can go to your conjunctiva, that lining of your eyes. And that's when you can get pink eye from having a cold also. Short incubation period of 1 to 3 days. That's where you'll have symptoms like headache and chills and fatigue and sore throat and cough and nasal drainage. But usually only lasts for about a week, and you're back on your feet and in action. Symptoms away from the nose are all usually the result of your immune response, like digestive issues, constipation, lack of appetite. All of that is because of your immune system, not because of the virus being in those areas. You can develop secondary bacterial infections of your respiratory tract after this. So you get the cold and then you happen to be exposed to, say, staph or strep or some bacterium. That can cause a serious infection afterwards because you're more prone to having your lungs and things infected if your nasal passages are already screwed up. So now going into our lower respiratory tract, where there's lots more excitement because the diseases are more severe and you're more likely to die from them. But diseases of the lower respiratory tract are going to be caused by many of the same bacteria and viruses as the upper respiratory tract. It's just in the upper respiratory tract, it's not affecting where your gas exchange happens, so you're not likely to die from it. If it gets to your lower respiratory tract where gas exchange happens, you could die from it. Bronchitis is going to be inflammation of the bronchi, branching into your two lungs. Bronchiolitis is inflammation of the smaller airways, so deeper in your lungs, and then pneumonia is where it actually affects those alveoli where gas exchange happens. So in that case, it went down your bronchi, down your bronchioles, all the way down to your alveoli. That's when your alveoli will fill with bacteria, and that leads to inflammation. You have the general response to inflammation, which is, leaky blood vessels. You want immune cells to come in, but you also have edema. That edema, excess fluid fills up your alveoli, and you can totally drown in your own fluids. So a lot of times when you die of pneumonia or you end up hospitalized with pneumonia, that's because you can't exchange enough gas, and it's the equivalent of filling your lungs with water. I think we made good progress. We can totally stop there. We'll finish this off on Thursday and then jump into digestive.